Hello, everyone, and welcome to Physics While I'm at It. I'm Dr. Patil, your faculty for medicine, and today with me we have Adil from Deccan Medical College, Hyderabad, and he is going to present a case on the valvular heart diseases. We've started taking these case presentations, and this is our third case, and hopefully we will learn to deal with our professors' questions that they pose during the Viva. So, Adil, let's go through the case. So, let's begin with the demography of the patient.
Good evening, sir.
Good
So
evening.
today I'm going to present a case on mitral stenosis. A patient named Mrs. Shanta Devi, aged 45 years, homemaker by occupation, who resides in Nagpur, Maharashtra, was came to the OPD and she was admitted on 16th July 2025.
Okay, so let me know about her chief complaints.
So she presented to the OPD with the chief complaints progressive breathlessness for 6 months
Okay.
and palpitations for 3 months and episodes of hemoptysis for 15 days.
Okay. So at this point of time, which system do you think are the important differentials here?
Uh, First will be cardiovascular system and then respiratory system.
Okay. So
And
can you tell me few causes for breathlessness which are related to cardiovascular system?
breathlessness in cardiovascular system can be because of mitral stenosis, first one,
Hmm.
and left-sided heart failure mostly,
Okay.
like aortic stenosis and mitral regurgitation, other things.
Okay. Hmm. From the respiratory system?
From respiratory system, it can be because of pulmonary embolism and COPDs, ILDs, and so many other
Yeah. Pneumonia, asthma.
pneumonia asthmas.
Okay. Now, the student's first point, as you see, he has listed the chief complaints in the chronological order. So whenever you're listing the chief complaints, make sure that you are listing them in the chronological order, the oldest first and the newest at the last. Okay. Now, can you tell me about few causes for palpitations from the cardiovascular system?
Uh, it can be due to atrial fibrillation
Good.
and so then supraventricular tachycardia
Hmm.
and mitral regurgitation
Yeah.
and
So
atrial defect.
good, good. So when you think of palpitations and cardiovascular system, I think the first thing you should think of is the arrhythmias, and
Right.
after that, the valvular heart diseases, as you said. Can you tell me few endocrine causes for palpitations?
Hypothyroidism and pheochromocytoma.
Good. So in hyperthyroidism, the palpitations may be persistent symptoms which may get aggravated on exertion. In pheochromocytoma, the palpitations will be episodic. Whenever the pheochromocytoma releases the catecholamines to the blood, they will have palpitations, rise in blood pressure, diaphoresis, all because of the sympathetic overactivity. Okay. Can you name few drugs which are known to cause palpitations?
Palpitations, like I am
I'll give you a clue. These drugs are often used as inhalers, but sometimes in the past we used to use them as tablets to treat asthma.
salbutamol,
The sympathomimetics like
symptomatic
salbutamol.
salbutamol.
Nowadays, we avoid giving the sympathomimetics orally because it can trigger the palpitations. Okay, and even tremors.
Tremors,
Now, your last complaint from the patient is hemoptysis.
pneumothorax,
So, what is the most common cause for hemoptysis in India?
TB tuberculosis, and then sometimes pneumonia and bronchitis.
Yeah.
But most
For the
common
Western
it's
world, the most common cause for hemoptysis is chronic bronchitis.
chronic bronchitis.
In India, chronic bronchitis is also an important cause for hemoptysis, but TB should be given the first priority. Okay, can you tell me any valvular heart disease which can present with hemoptysis?
Mitral stenosis.
And what is the mechanism for mitral stenosis patients to present with hemoptysis?
There is pulmonary congestion because of increase in left atrium. So there is also increase in the pulmonary artery. So there is pulmonary apoplexia where there is rupture of bronchial veins. So
Yeah.
patients can present it with hemoptysis.
Good. So, students, if you can give a detailed explanation behind the mechanism of hemoptysis in mitral stenosis, well and good. If not, at least tell your professor that, sir, hemoptysis in mitral stenosis is because of pulmonary apoplexy. If you're able to use the word apoplexy, most examiners will be satisfied with that answer. If anyone asks you to detail the mechanism, you can go ahead. Okay, so let's move to the history of present illness.
History of presenting illness, the patient was apparently asymptomatic before the patient started noticing increasing breathlessness. She has intermittent palpitations for 3 months, which was aggravated on exertion. And she
Okay.
had episodes of hemoptysis 15 days back, non-massive and without constitutional symptoms. And she presented with no chest pain, orthopnea, or syncope.
Okay. So first point is whenever you write the history of present illness, so from the complaints to history of present illness should always be in patient words. Once you go to the rest of the history, like the past history, drug history and all, where you can ask leading questions and refine it and write it in your words. Like past history, patient got operated somewhere. But when you look at the files, you get to know that it was appendicectomy done. So you can mention in the past history saying appendicectomy was done 7 years back. But when it comes to chief complaints and history of presenting illness, we should always keep it in patient's words and we should try to avoid the medical jargon as much as possible. So when we are listing the shortness of breath, you make sure that you tell it in patient's own words. You describe his story, saying that, sir, 6 months back, patient was not able to climb 3 floors, but since like climb 3 floors, but now he is not even able to get up from the bed. He feels short of breath to even do the routine activities. After that, if the professor asks you to grade the dyspnea according to NYHA, you can grade it, but try to avoid putting the grade in the history of present illness. Rather, describe it in the form of the patient's story. Okay. Now you have mentioned that patient had hemoptysis 15 days back, and you mentioned me that there is non-massive hemoptysis. So what do you mean by massive hemoptysis?
Acid hemoptysis is when there is more than 150 ml of blood or 150 ml of blood in one episode,
Yeah,
or 400 ml in a span of 24 hours.
good. 400 ml in a span of 24 hours is definitely a significant loss. So I will call it as massive. But any reason we call this 150 ml as massive if it happens in one single episode?
It can be an emergency situation.
No, it is something to do with your dead space. So what is the volume of dead space?
That's 500 ml.
No, the volume of dead
Sorry,
space
150,
is 150 ml.
150 ml.
So when you cough out 150 ml of blood, you can fill your own dead space.
One that's yeah.
And then you will literally choke in your own blood.
Mm,
So patients can die just because they coughed out 150 ml of blood, and if they are not able to puke it out, they can choke in their own blood and they
so,
can die. So that's why 150 ml in a single episode is considered as massive. Okay. Now you have mentioned here that patient did not have constitutional symptoms. What do you mean by that?
like fever, malaise, fatigue. These are all constitutional
How are they
symptoms.
relevant to hemoptysis here?
It, based on the other histories, it can be cardiovascular, but when we include the constitutional symptoms, it can rule out TB.
It cannot absolutely rule out TB, but of course, it's good to ask because if the patient had fever, especially evening rise of fever, malaise, it may be pointing towards an infection. And in the context of hemoptysis, it may be also pointing towards TB. So, good that you have asked. So, now here you have also mentioned that there is no chest pain, orthopnea, and syncope. Now, can any valvular heart disease present with chest pain or angina?
Yes, sir. Aortic stenosis can.
Yeah, good. So aortic stenosis and even HOCM can present with
Yes.
chest pain or angina. Okay. Now you mentioned your patient does not have orthopnea. What do you mean by orthopnea?
Orthopnea is when the patient goes to bed and there
Hmm.
is immediate breathlessness, onset of breathlessness. So
Hmm.
the patient tries to sit in an upright position, so the symptoms are
Shortness of
relieved
breath
normally.
improves or relieves immediately. What about PND?
In PND, it is usually when the patient goes to sleep, the onset is after 90 to 120 minutes. And then when the patient sits upright or in any other position, it is relieved.
Okay, so in the PND, even the relief is not immediate. It takes around 30 to
Immediate.
45 minutes.
30.
So in orthopnea, the onset of shortness of breath is immediate on assuming a reclining position, and immediately there is relief on assuming an upright posture. In PND, there is a lag of 90 to 120 minutes before patient feels short of breath, and lag of 30 to 45 minutes before he feels relief after taking an upright posture. Okay, so now syncope. Can you tell me few causes for syncope?
Syncope, in cardiovascular causes, you can have mitral stenosis and aortic stenosis. And common causes include vagovessels,
Yeah.
syncope, and other pulmonary causes of
Yes, so we can have syncope in many conditions, including Stoke-Adams syndrome,
stroke.
complete heart block, massive blood loss. But vasovagal is the most common cause for syncope. If you think of valvular heart diseases, mainly you should think of reduced cardiac output, as in case of aortic stenosis or mitral stenosis.
Mitral.
Is syncope very common in patients with aortic regurgitation?
Syncope, yes.
Now, in aortic regurgitation, we generally do not expect syncope because there the cardiac output is increased. So when
Okay.
the cardiac output is increased, we're unlikely to get syncope. Good. Okay, so at this point of time, what are the differentials you can think of looking at the complaints and the history of present illness?
Um, we can think about left-sided
Uh,
heart failures and other respiratory causes also.
Okay, good. So, Adil, you made a very important point because what I observe from students is that in the exam, because they get a hint that PG or a resident would have told that, okay, you are getting a case of MS or you are getting a case of AS, you are getting a case of stroke. So, by the time examiners ask you what are your differentials after complaints or history, they will first list that which they already know. Sir, this
Okay.
is my first differential diagnosis, mitral stenosis, and that gives us the examiners a subconscious clue that okay, you already know the case and you're trying to fit everything into it. So always keep it simple and open. At this point of time, even when I am listening to you, I am not able to decide whether we are dealing with a case of MS, AS, AR. But we know that either we are thinking of left-sided pathologies because there is dyspnea involved, or maybe a respiratory disorder. Okay, good. Now let's proceed with the past history.
Past history, the patient had a history of rheumatic fever at age 14.
Okay.
There's no history of hypertension, diabetes, tuberculosis, or any other comorbidities.
Okay, so now at this point of time, which system is most likely to be affected in this patient?
Here it is most likely to be cardiovascular system.
Okay, good. So till the history of present illness, we did not have the clarity, but once we have that past history of rheumatic fever, we are thinking of cardiovascular disease.
Cardiovascular.
Okay, so if patient had a history of rheumatic fever at the age of 14, which valve you think is most likely be affected in this case?
Mitral valve.
Okay. Now, what rheumatic heart disease does to mitral valve? MR or MS?
MS.
Okay. And then what is the difference between rheumatic fever and rheumatic heart disease?
In rheumatic fever, there is inflammatory reactions in the cardium. So usually it presents as pancarditis. All the
Mhm.
layers of the heart is affected.
Yes.
Uh, and in rheumatic fever, what happens is it leaves a scar in the
Yeah.
valve, in the
Mhm.
heart. So that that scar, because of repeated rheumatic fever, is called as rheumatic heart disease.
Okay, very good. So let me summarize it. So students, rheumatic fever and rheumatic heart disease are not same. Rheumatic fever is an acute immunological phenomenon where triggered by the group A beta hemolytic streptococcal infection, body produces immune reaction which causes because of immune molecular mimicry causes the damage to the all the layers of heart including valves. It causes valvulitis. When valves heal from the valvulitis, they heal with scarring or fibrosis. When again and again the rheumatic fever happens, multiple scars accumulate in the valves, making it stiff and difficult to open. So we end up with valvular heart disease. So once the scarring of the valve starts happening, then we call it as rheumatic heart disease. Before that, it is just an event of acute rheumatic fever. So during rheumatic fever, mostly patients present with mitral regurgitation. But in the rheumatic heart disease, because of repeated scarring, we would end up with mitral stenosis. Okay. So again, that is the relevance of the history. As we dig deeper and try to get information from the patient, the differential diagnosis starts becoming more clear. So just a couple of minutes back, we didn't know whether CVS or RS. Now we have the clarity that we are dealing with CVS case by looking at the history and by our sheer awareness that rheumatic heart disease mostly affect mitral valve. We're already thinking of the possibility of mitral stenosis. Okay, now let's proceed to the family history.
Family history, there are no similar cardiac illnesses or sudden deaths in the family.
Okay.
And
So before you go to the personal history, because you mentioned that there is no history of sudden deaths in the family, can you tell me few causes for sudden cardiac deaths?
sudden cardiac deaths can be because of aortic stenosis and
Okay,
um, hypertrophic cardiomyopathy.
good. Okay, so these are not the only causes. There are plenty more causes. If any teacher asks you what is the most common cause for sudden cardiac death, your answer should be ischemic heart disease. It's a very common story, right? Someone went to sleep and next day he did not wake up. He died in the sleep itself. Most of the times what doctors tell, they died because of heart attack, which we know that it was an episode of MI. But in relatively young individuals, it is hypertrophic cardiomyopathy. Aortic stenosis can also cause sudden cardiac death. Apart from that, there are a lot of other inherited conditions, especially where family history is involved. One of them is congenital long QT syndrome. So if the QT interval is long, it puts you at risk of developing tos series de pointes, a form of ventricular tachycardia, and people can die because of ventricular tachycardia or ventricular fibrillation. Then there is also one more condition which increases the risk of VT and VF. It's called as arrhythmogenic right ventricular dysplasia. So these are all common causes for sudden cardiac death. Okay, now let's proceed with the personal history.
Personal history, diet is mixed, appetite is normal, bowel and bladder is also normal, sleep is disturbed due to breathlessness, and there are no
Okay,
addictions.
okay. So is there any relevance of diet history when it comes to cardiovascular diseases? Are there any cardiovascular diseases which have their root cause or some contribution from the diet?
Yes, and it can be because of vitamin deficiency like wet berry and
Good.
also selenium
Yeah.
deficiency.
So selenium deficiency is known to cause dilated cardiomyopathy. Then wet berry we're all familiar with. So nutrition does have a role in case of cardiovascular diseases. Okay. So you mentioned that there is no addiction. So is there any correlation between addictions and cardiovascular disease?
Yes, sir, when addictions like alcohol addictions,
Hmm.
patient can develop arrhythmias. So that is also one of the differential diagnosis. So
Hmm.
it can be a cause.
Okay. So not just the alcohol. See, please remember the strongest risk factor for ischemic heart disease is smoking.
No,
Smoking is one of the strongest risk factor for IHD. Apart from that, alcohol, as you mentioned, alcohol increases the risk of atrial fibrillation, and we call it as holiday heart syndrome. Alcohol also causes dilated cardiomyopathy.
no,
Okay, so again, one more common addiction nowadays rising among youth is cocaine addiction. Cocaine is also known to cause dilated cardiomyopathy. And cocaine is a vasoconstrictor, so it can cause coronary vasospasm and it can trigger an MI. Okay, so now let's proceed to the general physical examination.
general physical examination, build and nourishment is average, pallor is
Mhm.
present, clubbing is also present, it is grade 1, pulse is
Mhm.
88 per minute, and it is irregularly irregular,
Mhm.
and blood pressure is 100 by 60 mmHg,
Mhm.
and SpO2 is 97% on Roman.
Okay, so let me start with build and nourishment. You mentioned it is average. Very often, patients with rheumatic heart disease. In fact, I have not seen a single rheumatic heart disease patient during my MBBS who was overweight or obese. They were mostly malnourished, emaciated, or underweight. What could be the reason?
Usually it is because of the interleukins, and the
Mhm.
interleukins release causes them cachexia, they become cachexic. And another cause can be because of lower socioeconomic status.
Okay, so very good. So first thing is that the rheumatic heart disease is more common in lower socioeconomic strata. The reason for that is the trigger for the immune system to get activated against our own tissues is group A beta hemolytic streptococcal infection, that to throat infection, which is more common in crowded spaces. So people with a lower socioeconomic strata live in closed spaces, crowded spaces. So they become more prone to develop the throat infections. So they become more prone to develop rheumatic fever and thus rheumatic heart disease. So as such, if they are from lower socioeconomic strata, at least not today, but in the past, the nutrition was a big concern. Getting calories to spend money on it was difficult for them. Second, yes, the rheumatic heart disease is a chronic inflammatory condition. And because of that, there is upregulation of interleukin 1, interleukin 6, and other inflammatory cytokines, which suppress the appetite and they're known to cause cachexia. Good. Okay. Now, you have mentioned that patient has grade 1 clubbing. So, can you tell me a few causes for clubbing?
Clubbing causes can be interest because of any vascular diseases and also pulmonary causes like interstitial lung diseases and bronchiectasis, other
Okay.
diseases.
Yeah, so mainly fibrosing or suppurative lung diseases like bronchiectasis is a suppurative lung disease. There is large amount of collection of the sputum and then usually infection of that sputum or the lung abscess, cystic fibrosis, ILD. These are the pulmonary causes. When it comes to cardiovascular causes, it is mainly the cyanotic congenital heart diseases. Will we get clubbing in patients with COPD? One of the common MCQ as well as a bedside discussion point.
No, sir, there is no club.
Yeah, COPD is not a suppurative or a fibrotic lung condition, so we're unlikely to get clubbing in patients with COPD. Even if you get clubbing, you should start thinking of other possible causes, and it is not likely because of the COPD directly. Okay. Now, while mentioning pulse, you mentioned that the pulse is irregularly irregular in the context of rheumatic heart disease, and we are already thinking of mitral stenosis. What does this mean to you? Irregularly irregular pulse.
It is an indication that there is atrial fibrillation in
Okay.
this.
Good, good. So it's a very good point. In fact, this is the importance of bedside discussion. Nowadays, the questions in the NEET PG are also not going to be those typical MCQ points. So in the recently concluded NEET PG, there was a same story. A female history of rheumatic fever presented with a mid-diastolic murmur, and she had this irregular pulse, and they were asking you to expect the diagnosis of atrial fibrillation. Okay, so whenever you have irregular pulse, first thing that should come to your mind, especially in the patient with mitral stenosis or anyone with the enlarged left atrium, is atrial fibrillation. Okay, one point I wanted everyone to notice that generally atrial fibrillation is a tachyarrhythmia. The heart rate will be quite on the higher side, usually 150 to 200 range you get. But you, when you go to the bedside, you need not always get atrial fibrillation with the heart rate in that range, because as doctors, once we recognize that someone is in atrial fibrillation, we try to treat. We implement some rate control measures like beta blockers or evaporating that might bring down the rate. So that's why don't diagnose atrial fibrillation purely based on the rate. Make sure you palpate for the pulse and you notice this irregular pulse. Okay, so BP for your case was 100 by 60. Assuming that we're dealing with a case of mitral stenosis, should I expect a normal BP or hypotension or hypertension?
In this case, we usually expect normal BP
Okay.
because
But
the
in mitral stenosis, as I understand, the cardiac output is expected to be low, and our systolic BP is directly proportionate to stroke volume or cardiac output. So don't you think it should be low?
no, sir, here it is compensated by the RAS system, so there
So
is no.
good. So whenever we have low cardiac output, especially not in an acute setting, but chronic low cardiac output, theoretically speaking, we should have low BP, but there is RAS. So there is also angiotensin 2, which causes vasoconstriction and kind of normalizes the BP. BP may be towards the lower limit of normal, but it need not always be in hypotension. Hypotension. Spam, that's the point I'm addressing. We're not expecting to see hypotension in all cases of mitral stenosis because we also have a counter-regulatory mechanism called RAS, which tries to keep the BP in normal range. Only when mitral stenosis is so severe that the cardiac output is severely reduced, which cannot be compensated by RAS, we end up with hypotension. Okay, so if this is a case of MS and the saturation goes low, is in hypoxic state, what should come to your mind?
Mm, like, can you repeat it?
So if we are dealing with a case of mitral stenosis and patient is in hypoxia, what is the cause we should think of?
It can be because of cardiovascular
Mainly
disease,
the severe increase in the left atrial pressure leading to
definitely.
severe pulmonary congestion or maybe even pulmonary edema can explain why
Edema.
we will get hypoxia. Okay. Okay, so let's proceed now to the systemic examination.
In systemic examination, during inspection, there was normal precordia, no visible pulsations.
Hmm.
Palpation, tapping apex beat, and there was palpable P2 sound. And in percussion, there was leftward shift of cardiac dullness. And
Hmm.
during auscultation, we found loud S1, opening snap, and mid-diastolic murmur with pre-systolic accentuation.
Okay, so let me start with the inspection. Okay, so generally at this point, as an examiner, I would tend to ask name few conditions where you get the visible pulsations in the precordial region.
Visible
Okay,
pulsation
so if you can name few.
uh, in endocrine process like hyperthyroidism.
So apart from that, the cardiovascular causes are also there. You can have visible pulsations in the neck, dancing carotids and all in patients with aortic regurgitation. You can have visible pulsations in the epigastric region in patients with tricuspid regurgitation. You can have visible pulsations in the left second intercostal space if you have pulmonary hypertension. Okay, at least these you should be able to tell. Okay, now coming to the apex beat. So when you mention the palpation, you should not only mention that the nature of the apex beat, but you should also mention the location of the apex beat. So in this case, if we are dealing with a case of mitral stenosis, what do you expect the location of the apex beat to be? Displaced or non-displaced?
Usually non-displaced, uh, but it
So in
can
what conditions the apex beat get displaced?
in hypertrophic cardiomyopathy is
Okay,
other.
good. So apex beat is located in the fifth intercostal space, medial to mid-clavicular line. That's the normal location. When it will get displaced? When either left ventricle gets dilated or develops eccentric hypertrophy. So in mitral stenosis, neither there is left ventricular dilation nor eccentric hypertrophy. So that's why we are not expecting it to be displaced. It will be there in its natural position, which is fifth intercostal space medial to midclavicular line. In patients with mitral regurgitation, there is eccentric LVH as well as dilatation. So where we can expect it to be displaced. In dilated cardiomyopathy, as you said, we expect it to be displaced. Okay, so in this case, we're not expecting it to be displaced. Some of you may be wondering what is this tapping apex beat. So in mitral stenosis, the S1 becomes loud and that loudness can be felt when we are palpating the apex beat and we describe it as tapping apex beat. Okay, so now in this context, when you mention palpable P2, what does that signify?
Palpable P2 is an
Right,
indication
student?
that there
Good.
is
Get the point.
pulmonary hypertension.
Huh. So any patient with left-sided heart disease, be it MS, MR, AS, AR, if you get a palpable P2, it is a pointer towards development of pulmonary hypertension. So now can I call this patient as having severe mitral stenosis?
Yes, sir. Because in
Yes.
severe
So
mitral stenosis, there is pulmonary hypertension.
yes. So it indicates that the problem that started in the left side of the heart has now crossed the lungs and reached the pulmonary artery. So we will count it as a marker of severity. So for any patient with left-sided valvular heart diseases, if you get a palpable P2, you can count that the left heart disease is severe. Okay. Just a comment on percussion. It's better not to comment about percussion because percussion does not hold much value when it comes to cardiovascular cases. Until and unless your particular unit or the professor wants you to comment about it, you don't need to do it. Most of the young professors will not ask you to comment on the percussion. It's just a futile exercise, waste of your 3 or 4 minutes of time. Okay. Then coming to the auscultation, one observation or a suggestion is that whenever you're mentioning the auscultation, make sure that you mention from which auscultatory area you documented these findings or in which area these findings were best heard. So without that, our auscultation description is not complete. Okay. So here you mentioned that you heard a loud S1. So can you tell me a few causes for loud S1?
Now, this one process can be because of mitral stenosis
Hmm.
and also um, other left-sided heart
Okay, not
failure.
the other left-sided heart diseases. Yes, whenever you think about loud S1, the first answer should always be mitral stenosis. At least this much you should know. As long as this much you know, you're mostly on the passing page. But if you want to score a little more when teachers talk to you about the loud S1, I want you to mention two more conditions. The second one is hyperdynamic state. Hyperdynamic state means in any condition where your heart is working more. Like if I run for 100 meters very fast, of course my heart needs to work more to generate more cardiac output that my muscles require. Then my S1 will become loud, which not only we auscultate, we can feel it. Literally we can feel it. Okay, apart from that, one important statement that I want all of you to remember: there is an inverse relationship between the loudness of S1 and the PR interval. Now, why is this important? Because PR interval is the period during which there is a time for the closure of the mitral valve. So if PR interval becomes shorter, the valve has to close in less time. And whenever we close something in less time, it makes more loud noises. Like if I close a door slowly, it makes less noise. But if I close it quickly, it makes more noise. So there is an inverse relationship between PR interval and the loudness of S1. So if I have short PR interval, I will have louder S1. And if I have long PR interval, I will have softer S1. So in case of the first degree AV block, where we have wide PR interval, we can have soft S1. But any other condition where there is short PR interval, for example, WPW syndrome, where PR interval is short, we can have loud S1. Spam, good, very good point. Okay. Now, what is this opening snap?
Opening snap is the sudden opening of mitral valve during the diastole.
Yeah. So basically, opening of the valves, it might be producing a sound, but it is not audible to human ears. We don't hear any sound when a normal valve opens. When the valves close, yes, we hear this S1 and S2. But if the valve is stiff and stenosed while opening, it may make a noise. That noise is what we call as either snap or click. They are pathological. Click is the word used whenever a valve that opens during systole makes the noise. So which valves open in systole? It is the aortic valve and pulmonic valve. So if I have aortic stenosis or pulmonic stenosis, we get click. And mitral valve and the tricuspid valve, they open during diastole. So while opening, they make a noise. We will call it as snap. So we use the term because opening act is making that noise. We call it as opening snap. Okay. Now, the murmur. So which area the murmur of mitral stenosis is expected to be best heard? Spam, very good.
During passive filling of the
No, no, the auscultatory area where I will hear it best.
in the fifth center, not
Yes. So mitral area is the apex, and it is in this case undisplaced. So I'm expecting to hear the murmur in the fifth intercostal space, medial to midclavicular line. Okay. So this mid-diastolic murmur has a pre-systolic accentuation, means just before the systole begins, it becomes louder. What is the mechanism behind that?
in passive filling. Mostly it is transferred because of the pressure
Hmm.
difference
Hmm.
from the atrium to the ventricle.
Hmm.
And in the active filling, the atrium contracts more and pushes the blood to the ventricle. So in this case, it
Yes.
contracts more and there is a turbulence in
Ah,
the valve. So we
good.
can hear more.
Good, good. So basically, murmur is the sound produced by the turbulent flow of blood. So during passive filling, there is turbulent flow because of the narrow mitral valve opening. It is already making a noise. That is the mid diastolic classical murmur. But during the active filling, atria contracts more. So it creates more turbulence across the mitral valve. So the murmur intensity increases. So in the 2025 NEET PG, there was this question of mitral stenosis, and they were primarily asking the mechanism behind this. In that case, there was loss of presystolic accentuation. Case of RHD, MS, but only mid-diastolic part of the murmur is heard, and this presystolic accentuation is lost. Can you tell me in what condition that can happen?
Mitral regurgitation.
Yeah, MR is one. Okay. In what other conditions?
And one, yeah,
See, this is because of the active filling, atrial contract. But what if atrial does not contract?
there won't be any
So in what condition atria does not contract?
real contact. And,
This patient has that condition.
um, Mitral stenosis.
No, mitral stenosis, of course, atrial contracts. Pre-systolic accentuation is there because of that. This patient has an additional complication of mitral stenosis where atria does not contract, irregular pulse.
Atrial fibrillation.
So in atrial fibrillation, atria is not contracting, it is only fibrillating. So if it does not contract, it does not create that extra turbulence. So we will not have that pre-systolic accentuation. We will only have that flat mid-diastolic murmur, right? So please remember this. Whenever teachers ask you, when do you lose this pre-systolic accentuation? You can say, sir, MR and atrial fibrillation. In this case, what is your primary differential? Atrial fibrillation because patient has irregular pulse. Okay. So let's proceed to the other system examination.
Respiratory system, there is normal PA and bilateral basal crepitations. In abdomen, it was soft, non-tender, and no organomegaly or any sleep fluid was there. And in CNS, the patient was conscious, oriented to space and time, and there were no focal deficits.
Okay, good. So now going to the respiratory system, this patient has bilateral basal crepitations. So can you explain what could be the reason for this patient to get these basal crepitations?
Basal crepitations is because of pulmonary congestion. So
So whenever we have these basal crepitations, we should think of pulmonary congestion or pulmonary edema. Is it expected in this case?
yes, sir.
Mitral stenosis, so it is expected. So we can get to know that patient has developed the pulmonary congestion or edema. Okay. Now, what is the relevance of abdomen examination in serious cases?
In serious cases, due to right-sided heart failure or
Mhm.
right-sided heart diseases, you can see ascites. That is
Good.
one indication. Then we can also have hepatomegaly
Mhm.
and pulsatile liver and epigastric pulsations.
Good. So first of all, the relevance of severe abdominal examination in serious cases is that we can have various manifestations of serious involvement indirectly on the abdomen. So one is ascites and the hepatomegaly, which is often tender. We also call it as congestive hepatomegaly in patients with right heart dysfunction or right heart failure. Apart from that, patients with tricuspid regurgitation can have a pulsatile liver, a very important, repeatedly asked MCQ point where you get pulsatile liver, tricuspid regurgitation. And you can also have the epigastric pulsations in the tricuspid regurgitation. The reason for that is during systole, the blood regurgitates from the right ventricle to the right atrium. And that entry of blood from the right ventricle to right atrium increases the right atrial pressure, and that pulsation gets reflected to inferior vena cava, from inferior vena cava to liver and the epigastric region. So we get these pulsations. Okay, very good. So now looking at the history and the examination findings, what are your differential diagnosis?
So first would be mitral stenosis because of the past history of rheumatic fever.
Mhm.
And after that, there is left atrial myxoma, then
Mhm.
severe tricuspid stenosis and quad triatrial.
Okay. So left atrial myxoma, I can understand because there is a tumor in the left atrium which can block the mitral orifice and behave exactly like the mitral stenosis because of rheumatic heart disease. So clinically, maybe a bit difficult to distinguish. But why do you consider tricuspid stenosis as your differential diagnosis?
Because of the murmurs and other findings in the inspection and auscultations, there is a possibility that it could be tricuspid stenosis also.
Okay, see, I agree. Murmur point of view, it could be tricuspid stenosis because murmur of MS and murmur of TS is same. That is mid-diastolic murmur with pre-systolic accentuation and opening snap in both cases. But if I had tricuspid stenosis, mostly I would have presented with raised JVP, hepatomegaly, and ascites, the right-sided symptoms. In mitral stenosis, I will present with dyspnea and the left-sided symptoms. Okay. On auscultation, is it possible for us to differentiate between TS murmur and MS murmur?
Yes, sir. And usually in right-sided heart diseases, we auscultate during inspiration,
Hmm.
and in left-sided heart diseases, we auscultate during expiration because it is more heard in expiration.
Okay, good. Anything else?
Um,
Is there any relevance of area of auscultation?
yeah, there can be this, the apex beat can be displaced in
Not just
different
that.
conditions.
So first thing is that the murmur of mitral stenosis will be best heard in the mitral area. In the
Uh,
other areas, it may not be heard, or if heard, it is not going to be as clear as we hear it in the mitral area. On the other hand, murmur of tricuspid stenosis will be best heard in the tricuspid area. It may not be heard in the other areas, or if heard, it is not going to be as clear as we hear it in the tricuspid area. So area is different. Second, symptoms are different. Right side symptoms here, left side symptoms here. And as you mentioned, if I look at inspiration versus expiration, the murmurs originating in the left side of the heart will be best heard in expiration. So if it is MS, the murmur will be loud during expiration. And murmurs originating in the right side of the heart will be best heard in inspiration. So if it is TS, I will hear the murmur louder in inspiration and it will become less louder during expiration. Good. So looking at all your complaints, I think the complaints history and examination findings, I think this case is clearly a straightforward case of mitral stenosis. Tricuspid stenosis is not a closed differential. It's a very distant differential. Okay. Then left atrial myxoma is also rare, and the context of rheumatic fever makes it very clear that our priority differential diagnosis is mitral stenosis. Okay. So if it is a case of mitral stenosis, how will you manage this patient?
Firstly, we will have to start with the penicillin prophylaxis
Okay.
because the patient is past known case of rheumatic fever.
Okay.
Then also symptomatic wise, we can use diuretics to
Mhm.
bring down the cardiac output, the lung volume, reaching the
Mhm.
lungs volume. Then
Congestion. Okay.
surgical procedures, we can do balloon mitral valvuloplasty.
Okay. So let me start with the basics. So if this is a case of rheumatic heart disease, already valve is affected. So for what reason we are giving the penicillin prophylaxis?
Uh, to avoid more recurrent uh, rheumatic fever.
Okay, good. So if mitral valve is affected, it doesn't mean that the other valves will not be affected. So a patient continues to experience rheumatic fever episodes again and again after mitral valve, even the aortic valve is the next most commonly affected. It can even affect the rheumatic heart disease can even also affect the right-sided valves eventually. So the more valves get involved, the condition becomes more complicated for the patient. Like imagine mitral stenosis, already reduced left ventricular filling, plus aortic stenosis. So severe reduction in the cardiac output. Mortality rate will become very high. So even if I have a mitral stenosis now, I don't want the other valves to get affected. So I will keep the patient on penicillin prophylaxis. Okay. Now, audience, can you tell me, is it required for us to give the penicillin prophylaxis in this case? Okay. So let me know through the Instagram or the social media comments. Keeping the age of this patient in mind, do we need to give the penicillin prophylaxis or not? I will leave it to you. We'll discuss it in the next class. Okay. Then second, you made a mention about the diuretics. Only thing I would like to add is that we need to be very cautious while giving diuretics to a patient with mitral stenosis because their cardiac output is already low. Diuretics will decrease the end diastolic volume and decrease the cardiac output further. Yes, they will reduce their pulmonary congestion and make the dyspnea better, but reducing the cardiac output can lead to syncope more often. So we need to be very cautious. We can use it, not an absolute contraindication, but we need to be cautious. Okay. Now, in terms of definitive treatment, we consider balloon mitral valvuloplasty or balloon mitral valvotomy. Can you tell me some contraindications for this procedure?
Uh, we don't do it in any clot in the left atrium
Mhm.
because if usually in this procedure we try to dilate it more. So there is a possibility that the clot could go in the circulation and cause thromboembolic stroke.
Okay.
And second case is during mitral regurgitation. If it is associated with mitral regurgitation, then we cannot
Yeah.
dilate it more.
Okay. So basically, what we do in balloon mitral valvotomy is we pass the balloon across the mitral valve and inflate the balloon so that we dilate the valve. So it is narrow, we dilate it. The problem it can cause is once we dilate, it may not be able to close properly. So procedure of balloon mitral valvotomy itself may induce some degree of mitral regurgitation. But if patient already has moderate or severe mitral regurgitation, it will become even more worse. So that's why it is a contraindication. Second contraindication, as you mentioned, if there is a clot in the left atrium, after we dilate, we make it easier for the clot to migrate from left atrium to left ventricle and then get embolized to the brain and cause stroke. So it becomes a contraindication. The third condition is where you have a severely calcified mitral valve because it is not going to get dilated easily if it is severely calcified. In these three conditions, there are contraindications. Now, if I have contraindications, what is the best treatment I can offer for the patient?
Now we can do conservative treatment instead of surgical procedures,
Hmm.
or you can also have valve replacement surgery.
Good. So ideally, we should go for the valve replacement in such conditions. But one point to remember here is that if there is a clot in the left atrium, it's not an absolute contraindication for the balloon mitral valvotomy. We can go ahead with an anticoagulation, wait for the clot to dissolve, and once the clot is no longer present in the left atrium, we can go ahead with the balloon mitral valvotomy. But if I have moderate or severe MR or severely calcified mitral valve, then I can't go ahead with the balloon mitral valvotomy. In that case, I have to go ahead with the valve replacement. Valve replacement is a open heart surgery. So of course, patient needs to be fit for it financially as well as medically. In some cases where the disease is advanced or patient is not financially fit, we have to resort to conservative treatment. Okay. Now this patient has atrial fibrillation. How would you manage that? Because irregular pulse we said. So how will you investigate? What investigation you will do and what treatment we can give?
Basic investigations will do ECG and uh, echocardiogram.
Good. Hmm.
Then by management, we can give rhythm control drugs like digoxin, beta blockers.
Okay. So that's a quick summary, but let me be a little more detailed. So whenever we have atrial fibrillation, we need to look at the duration. If it is a long-standing atrial fibrillation, there is a possibility that patient may have a clot in the left atrium. So in most cases of RHD, the atrial fibrillation, by the time they present with palpitations, it's already long-standing. So when you mention the complaint, duration is not 48 hours, right? She had complaints for a few months now of palpitations. So it is a chronic atrial fibrillation. So there's a possibility that she may have a left atrial clot. So I will do an ECG to confirm the diagnosis of atrial fibrillation. After that, to make sure that there is no clot or presence of clot in the left atrium to be identified with the echocardiography. What route will you prefer, a transthoracic or transesophageal?
Transesophageal because
Because,
it is
good, good, good.
positioned very posteriorly. So
The left atrial appendage, where clot usually develops, is positioned posteriorly, not well visualized through the transthoracic echo. So we need to do a transesophageal echo. And if the echo picks up a clot, then we should not convert the rhythm to sinus immediately. So in that case, we have to just control the rate. For rate control, we can use beta blockers or evaporating. And during this period, we have to give the anticoagulation. Once 3 weeks of anticoagulation is done, hopefully clot would have disappeared. Then we can go for the rhythm control. But if there is no clot, I can try to convert the rhythm to sinus. So for that, yes, there are various drugs. We can consider amiodarone, or we can consider digoxin. Amiodarone is right now considered as the good drug when it comes to the conversion of atrial fibrillation from arrhythmia to sinus rhythm. But again, we have to also look at the patient's blood pressure. If patient is in hypotension, there is no role of pharmacotherapy. Here I'm talking about pharmacotherapy because patient's BP was 160. If patient BP was less than 90/60, there is only one way that we can manage any arrhythmia, not just the atrial fibrillation, and that is shock. Anyone with low BP, arrhythmia should be shocked. Okay. And one important point we need to address here is that even if there is no clot in the left atrium, I'm going to try to treat the arrhythmia with drugs or shock depending on the BP status, but I still need to consider the anticoagulation because clot may not be there now, but because atria is not contracting, there is stasis and a clot may appear and patient can develop embolism later. So I need to consider anticoagulation. Now, in a case of atrial fibrillation, if I have to decide whether I need to give anticoagulation or not, what tool do we use?
There is a score called CHA
Huh.
DS.
Yes, good. It is called a CHA2 DS2 VASC score. So, as an examiner, I might ask you what are the conditions where we decide to give anticoagulation without looking at the CHA2 DS2 VASC score?
In natural stenosis and uh, in it, in regurgitation.
So basically, any patient where atrial fibrillation is because of a valvular heart disease, especially rheumatic, there is no need to calculate CHA2 DS2 VAS score. Directly go ahead and start them on anticoagulation. Second is any patient who has the past history of stroke. We don't need to calculate because we give the anticoagulation when the CHA2 DS2 score is 2. And if you have the past history of stroke, we already give 2 points for the stroke. That is the S2. So no need for the calculation of CHA2 DS2 as score. And one new important MCQ point, patients with hypertrophic cardiomyopathy, they are also at high risk of developing the atrial fibrillation, and they are also at high risk of developing thromboembolism. So if there is HOCM, no need to calculate CHA2 DS2 as score. We can directly go ahead and do the anticoagulation. Okay. So Adil, I think that was a very good and neat presentation. There were few corrections that I have suggested, mainly keeping the complaints and the history in the patient words. Okay. And then the second thing is that when we describe the murmur, describe it very methodically, which area it is best heard, what was the position of the patient when the murmur was best auscultated, whether he's sitting, lying down, left lateral position, right lateral position, and what is the relationship with respiration, whether it was best heard in expiration or inspiration. That makes it a complete description of the murmur. And another important take home message to all the students is that don't bring in those symptoms, complaints, or diagnosis that you're not fully aware of. Once you bring those words